Welcome to the Everything Epigenetics podcast, where we discuss DNA regulation and the insights it can tell you about your health. Hello, everyone. My name is Hannah Wendt. I'm the founder of Everything Epigenetics, and today my guest is Dr. Josh Routh. This is a really interesting episode where we start off talking a little bit about who Josh is and the problem with cancer burden and late detection. We cover the current state of cancer diagnostics and the future state of cancer screening tools. We talk about the current American Cancer Society guidelines and their recommendations for routine screening, and where we hope to actually be able to start to detect cancer earlier through epigenetics. Yes, that is correct. We're looking and discussing at cell-free DNA in the bloodstream. Josh works at Precision Epigenomics that offers one of these tests that can test early cancer signals called EPISEEK. So we explain more about these tests, the promise that they hold. How does one actually perform this type of test? What does it actually test for? What's the sample type, the specificity, the sensitivity? How do we even define what specificity and sensitivity means in this case of testing? Who should actually take this test? What do these results look like? And what happens if you get a positive signal? We also talk about the difference between EPISEEK and the Galleri test by Grail, which most people are probably familiar with. Lastly, we end up with other areas that Josh is really excited about when it comes to epigenetics in cancer diagnostic tools. A little bit of interesting information about my guest. Josh is a broad background in pathology and laboratory medicine, and specific training and expertise in bioinformatics and molecular oncology. He has a lot of broad experience. He oversees a clinical laboratory that performs next-gen sequencing, whole exome, whole transcriptome sequencing of cancer samples for patients with advanced cancer. He has provided leadership to a broad range of clinical laboratories, academic, government, private, and public. He is a jack of all trades, and he received his MD from the University of Arizona, completed a residency in anatomic and clinical pathology, as well as a fellowship in molecular genetic pathology at the University of New Mexico. He is now an associate professor of pathology at Midwestern University with research focusing on molecular diagnostics and precision medicine. If you don't know what all of that means, don't worry, we're going to hop into it. It's the first question where we learn a little bit more about Josh. And now for my guest, Dr. Joshua Routh. Welcome to the Everything Epigenetics podcast, Josh. I'm excited to have you today.
Thanks, Hannah. I'm excited to be here.
Yes. So we first met. You work for Precision Epigenomics, and I'm obviously at True Diagnostic, and we offer your EpiSeq liquid biopsy testing, which we'll jump into during this podcast episode. But you're the laboratory medical director there, and you're an APCP board certified pathologist with additional fellowship training in molecular genetic pathology, and you serve as medical director for the clinical laboratory. What does that all mean? Tell us a little bit more about your journey. You know, I'm sure people listening may be interested in pursuing some type of career like that one day. What got you there as well?
Yeah. I had a pretty weird career path. I actually started out as an electrical engineer. So I was designing microprocessors for a company called AMD. They make the computer chip in your computer that you're using right now. Ended up going back to school, going to medical school. And I got there and I was kind of disappointed. There's almost no math in medicine, right? Very little math, which none of my classmates were disappointed with. But I found this field of informatics within medicine and also pathology. And I was really attracted to pathology. The clinical lab is kind of this nexus where all this information about a patient comes and then all these results come out. There's a statistic out there that says 80% of medical decisions are based on a laboratory test result. And that was compelling to me, and it was a good fit for my personality and my experience as well. So finished up medical school, went and did a fellowship a residency in anatomic and clinical pathology with a lot of focus on the clinical kind of lab management side there. Around this time, too, next-gen sequencing was really emerging as technology and, generates up to 40 gigabytes per patient. And that is my sweet spot. Writing code to analyze that data to help these patients was just a great marriage of some of the things I had experience and interest in. So I did a fellowship in molecular genetic pathology, worked a lot at the kind of bioinformatics side of things, got experience as well in the wet chemistry, came out of training, so excited to change the world. I got my first job working for the Department of Veterans Affairs. So the VA was launching their first kind of next-gen sequencing laboratory. They hired me to be the lab director and then awarded the money for the lab to another state, which only the federal government would do that. So I got to know the people in both laboratories, managed the local laboratory there. We were successful at that. We were doing next-gen sequencing of veterans' tumors to determine what was the best drug to give, right? So with their particular mutations, what should they be getting? From there, I left and I worked for a company called Exact Sciences. Huge company. They were buying up smaller laboratories at the time, and I came in to direct some of their next-gen sequencing laboratories. So had a great time working with that company. Really happy there. But I really liked the small companies that they were buying and some of the innovative work that was happening at the smaller companies, and not as much, the big corporate structure. So I took a teaching and research position at Midwestern University. That's where I am now. I teach medical students, the next generation of doctors here, the DO students. And then I also do clinical work with a few different laboratories, kind of doing scientific oversight, medical oversight, making sure the tests are meeting the standards, and then using some of that background to design tests.
Yeah, and you're loving it. It seems like, right? It's like a marriage of almost all of your skill sets where you still have.
It's
Yeah,
impossible to, how could you have picked this? If I went back in time 10 years and said, what do I want my career to look like? I couldn't have imagined this piece, but it's been a really fun journey.
good. Yeah, you're in the lab. You still have that analytical piece of it with precision epigenomics and what you're involved now. But I think I was familiar with your teaching at Midwestern and what you've been doing too. So you still get that kind of person-to-person interaction and able to pass off your skill set to the next generation too. So
Absolutely.
that's
Yeah.
awesome. Well, today we're really here to talk about cancer and epigenetics. And I've spoken about this on the podcast once before with Dr. Kristen Bird. She's at Ohio State. And that was, a pretty different episode compared to what this one's going to be about. We're really going to talk more about how we can, look at new cancer diagnostics tools through the lens of epigenetics and what epigenetics can really teach us. So I have some statistics here I want to read off before we really hop into it. The problem is cancer burden, right, and late detection. I see it everywhere over my social media accounts and the news. There's this increase in cancer diagnostics. I have healthcare providers I work with send me articles that, in 50 years or so, 90% of the world is going to have some type of cancer, by the age of 65. So just to name off some of those statistics, over 2 million new cancer cases are expected to be diagnosed in the U.S. in 2024 alone, just this year, with about 600,000 deaths from cancer expected in the U.S. Last year. There's about $209 billion per year spent on USA cancer-related healthcare cost, which is insane. And there are only currently 4 cancers, lung, colon, breast, cervix, that have routinely recommended conventional screening tests, which usually underperform, not in the way that we really want them to reach our standards. And then lastly, which I think this is crazy to even talk about as well, over 60% of cancers are diagnosed in late stage. And, I've been lucky enough in my immediate family to not have a huge history of cancer, but I mean, cancer touches everyone. My step grandmother, who I love dearly, passed away from lung cancer. And I remember just wishing, and this was only a couple years ago, that there was some type of test to diagnose her early. I mean, it was way too late. We really couldn't do anything about it. So, Josh, I want to throw it over to you. What do you see is wrong with this in your area? Like, what isn't wrong with this, I think is the correct question.
Yeah, I think we definitely know catching cancer early when it can be kind of completely treated and gotten rid of, we have better outcomes, right? We have decades of information backing that up. We also have decades of information of trying different cancer screenings that have been successful and not successful to varying degrees. That's the work that we're doing at Precision Epigenomics is trying to detect cancer earlier, trying to get that final diagnosis as soon as you can, so you can get that earlier treatment. I do think in the next 10 years, this is going to be standard of care, right? You're going to get a blood test for, A1C to see if you have diabetes, right? You're going to get a blood test to say, hey, is there any cancer here that's undetected currently that we could find and treat before it becomes a stage 3 or stage 4, metastasizes or requires a big surgery. So yeah, I think that's the goal. It is troubling seeing the statistics of cancer rates increasing, especially in the younger population, and trying to understand why that's happening too. We don't have, there's a bunch of, possible reasons for it. I think obesity, diet, lack of exercise are three of the big things that we're looking at. We're looking at environmental contaminants as well, some of these forever chemicals as possibilities there. Regardless of what is causing it, right? It's becoming more of a problem, right? It's not like cancer is an old disease that's going away. It's becoming more relevant. We need better tools to treat it.
Definitely. And I know I named those, the American Cancer Society guidelines. They have that routine screening for 4 cancers: the breast, colorectal, cervical, and lung. Would, my mom, for example, she just went and got a mammogram. So would that be considered cancer screening or just more of like preventative screening?
Totally. Yeah. So mammograms are a primary cancer screening test, right? You're looking for cancer that's there that isn't symptomatic yet.
Right.
And so mammograms, again, we've got a pretty good success story there where we are catching breast cancers earlier than before that technology existed. But there's a lot of issues with that screening modality as well, right? No test is perfect. No lab test and radiology test is perfect. So with mammograms, you can have false positives. You can have a lesion that's found that causes concern in a patient like your mom, right? And then a biopsy, that's not nothing. That's something that's happening. And so it's important, right, to scrutinize the tools that we have, celebrate the victories that they have. I think there are millions of women probably, right, that beat cancer as a result of those screening programs. But that doesn't mean it's perfect, right? I think we should keep driving and keep trying to find earlier things. I think with prostate cancer, PSA is kind of an interesting talking point, right? Where it's somewhat controversial. And if your listeners here, I'm sure, are a lot of primary care doctors, it's maybe split 50-50. Who gets PSA on all their patients and who doesn't? And looking at the data, it makes sense, right, that there's some controversy there because there can be some positives that come out of it. There can be early detections, but there can also be situations where, indolent cancer that's non-aggressive is detected and treated. And I've got a story, in my family of somebody that had a prostate cancer that was detected and treated, but he also had kind of an end-stage neurological disease. And so the question in my mind is, did this treatment, was it helpful or did it actually progress this other disease, right? And I think, looking at statistics and papers kind of removes some of the human element from, having a recommendation of always do X for patients and insurance companies will only pay for X. Remove some of that human element of, in this particular situation, it makes sense to do this test or it doesn't make sense. And that's where the role of that physician, right, that kind of healthcare advocate comes into play to look at that situation and scrutinize it and make a recommendation.
Yeah, definitely. Thanks for sharing that story as well. I know my mom wasn't happy to get her mammogram, and it's uncomfortable, and you have to get out of your own house. You got to be able to, afford it, make sure you have the insurance, line up all of the logistics, and then get yourself to actually go. So all of these kind of treatment, I don't want to call them treatments, cancer screening test, and, you know, um, you have to think of the availability to the end user, and then, how likely is it for them to actually go and get the screening too. So
Mhm.
I think there are ways that these tests can become more easily accessible to people too. So just to recap, those cancer screening tests, they really are looking to find cancer before it causes symptoms. It may be easier to treat that successfully, and usually these effective type of cancer screening tests find cancer really early. Reduces the chance that someone who is screened regularly will actually die from that cancer. And then hopefully it has more potential benefits than harms. So you mentioned a couple, but possible harms of screening tests like bleeding, physical damage, false positive, false negative test, overdiagnoses as well.
Mhm.
So diagnoses of cancers that would have not caused problems and did not need that actual treatment, like you may have mentioned. So
Yeah.
Josh, what do you think? How can we actually detect cancer earlier, even before these types of screening tests?
Yeah, it's a solid question, and we're talking about epigenetics today, right? And so one of the things that the scientists at Precision Epigenomics landed on was that cancer is a pretty diverse set of diseases, right? We sometimes refer to it as one thing, right? We say 95% of patients will get cancer by 65. That stat you shared earlier. That's not currently the case at some future state, right? But really, it's a lot of different. Basically, every person is different, right? Every pathway that cells take to become cancer is different. And so, one of the problems you run into trying to look at a biomarker test is you may have something that this for sure means it's cancer, but it's only present in 1% of cancer, right? One of the advantages to using epigenetics is that cancer has, a lot of things that happen and change, and a lot of pathways converge by turning genes on and off with epigenetic switches, right? And so what the test that P is offering, EPISEEK, can do is look at some of those common endpoints where multiple cancers at multiple sites converge together. So take a really close look at a handful of methylation sites to be able to detect that cancer. So you mentioned some of the limitations with screening, right? Having to logistically schedule it. Maybe you live in an area where mammograms aren't always available, right? If you're in somewhere rural, um, this is a blood test, right? Looking at cell-free DNA, circulating cancer DNA, looking for these common endpoints and trying to detect cancer early. That's certainly one approach, and one that I think is a solid one. Obviously, I've got my name on those reports, so I think it's a good one. But there's other approaches as well that people are trying, where there are new radiology tools coming out, right? Some AI-assisted tools that can look at features of images that humans just can't detect, right? A human can't look pixel by pixel for some sort of granularity that an AI tool can do. So radiomics is that kind of field of these advanced tools to try to detect cancer more accurately. There's protein biomarkers. There's a lot of work going on right now in proteomics. We've got new tools coming out that let us look at more proteins at the same time at a more sensitive level. And so I'm excited for that work and to see that integrated in with some of the tools we have. So I think there's a
Yeah.
lot of tools here. Yeah, and I think the important things are how cheaply can we do it, how accurate can we make it, and how easy can we make it for patients.
Yeah, definitely. And when you talk about the AI type of tools where they're reading this imaging, are you familiar with like Prenuvo and the Clearly heart scan by chance? Well, the Prenuvo is the MRI or the body screening, and then Clearly like the heart screening. I know some of our healthcare providers are starting to use those a lot more on top of even these cancer screening tests or things like the EpiSeq too.
Yeah, I'm certainly not an expert on those things. Yeah, I think
Yeah.
it's very cool. I'm interested in it academically because I think it's a different type of information, right? if you're looking at the same types of information, there's only so much like statistical power you can add to make a test better. But when you take in another domain and add it together, right, I think that you're able to really help sensitivity and specificity, right, at the same time by putting pieces together. Right now, that happens in your doctor's brains, right? They get multiple tests together, put those things together, and make a decision. And so I'm excited that it's not just us in the genomics world trying to solve this problem. It's really across disciplines, across specialties, trying to solve.
Yeah. I'll send those companies to you. I think you'll be super interested in them. But I think one of the issues with them is that they're so new. So whenever I'm asking the providers, hey, are you using this new technology or have you seen this new screening capability? They're only in a couple hotspot locations within the U.S. So
Yeah.
It's very rare that providers actually have this technology in their practice. Usually the patient has to have a script for it and drive a couple hours or even fly somewhere as well. So although it's really a cool new tool, scans for a lot of cancers, looks at a lot of different biomarkers from this imaging techniques, it's still limited in some ways too. Yeah. So we mentioned you're at Precision Epigenomics and you offer this testing called EPISEEK.
That's right.
So
yeah.
This would be called a multi-cancer detection test. Is that correct?
That's correct. Yeah.
Okay.
That's the term that's floated around there right now. There's some NIH work groups looking at it. The CDC has a work group looking at it. We used to call it multi-cancer early detection. We dropped the early. I'm not totally sure why. I think because we can detect it. We want to be clear. It detects late cancers as well. So.
Gotcha. That makes sense.
Yeah. So that's this domain of multi-cancer, right? Instead of one that's targeted. So there are some phenomenal tests out there. You mentioned, for those four cancer types, right? There are tests that are cancer type specific. One of the issues with that, right, is you may have a great test for colon cancer detection, right? So Guardant has this new test Shield that's out there with some phenomenal data. It's a blood-based test for colon cancer, but it is specific, right, to that one type of cancer. And my concern too is there are already some pretty solid options out there. Colonoscopy is a great option if it's available to you, if you can afford it. Cologuard, I used to work for that company. I think is a phenomenal test. I've seen behind the curtain what's going on. I think I again think those are fantastic results that have helped a lot of people. I think casting a broader net and being able to detect more cancers allows you to really catch, more patients in the net at the same time.
Yeah. And just to recap for the listeners as well. So these multi-cancer detection tests, they're blood-based. They're also called liquid biopsies, and they're really designed to try and find more than one cancer at a time at a more treatable stage, usually in asymptomatic patients. So they're designed to be used alongside of existing screenings, usually developed and studied by multiple companies, top cancer research institutions, and America across the world. They're not yet approved by FDA, which is okay. A lot of these new technologies aren't yet, and they're not covered by Medicare or other health insurance plans. But definitely, hopefully, in the future, they would be too. So. I think, Josh, we were going back and forth via email about this, and maybe this is a limitation or my ignorance in understanding this. So I've also heard, though, people call these tests stage 0 liquid biopsy cancer screening tests too. But I think you corrected me there. So I want to know the difference between just these early multi-cancer detection liquid biopsy test and maybe I even just made it up, these stage 0 liquid biopsy cancer tests too, or if that's an option, if that's a product.
Yeah. So I'm a pathologist, right? That's my training. So I've got a microscope here in the background. It's not just for show. It is a real functional microscope. So cancer staging, right, is part of the job of the pathologist. So you're looking at clinical information. You're looking under the microscope at the extent, some of the features of the disease, and you're giving a stage. So the stages that are out there, the main stages are 1 and 2. That's kind of localized disease, the earlier stage disease. 3 could be regional spread, right? And then 4 is often metastatic. And there's a big thick manual that I've got behind me here with for every cancer, what features put it there, right? It's called the AJCC Cancer Staging Manual. So stage 0 in that context, and that's the context that my brain works in, and marketing professionals like to take the technical terms, right, and apply them elsewhere. Stage 0 is an in situ disease, right? So that means that the cells have changed, right? Some of the cancer hallmarks are there. So the malignant potential is there, but it hasn't crossed through the basement membrane yet, meaning it's still in the place that the cells are supposed to be. So the cancer cells haven't gained the ability to spread in the body, right? Even, to the other part of the breast, right? So ductal carcinoma in situ, that's a stage 0. Is it a cancer? Is it not a cancer? That's also open for debate, a semantic argument there. I think that there is definitely a movement to detect cancer even before it's invasive, right? And if you look at some of the controversy around existing tests, their performance for detecting like a colon polyp, right? So colon cancer is one of the ones where you can treat the cancer before it's even technically cancer, right? It's an adenomatous polyp. We know it's on its molecular way to becoming a cancer. It's got epigenetic modifications, but it hasn't yet started invading the rest, right? So we'd either call that precancerous or possibly a stage 0 cancer, depending on your terminology. There's definitely value to detecting that and treating that early. I think some of the language is coming out and saying, yeah, we want to catch that early and detect it early. So maybe we're targeting stage 0 before it's even technically a cancer to treat. Designing clinical trials, which is part of my job, it's difficult, right? Because if we don't have a gold standard for detecting these, so you're not going to see any graphs from multi-cancer early detection saying, what's our stage 0 detection rate? Because we don't, again, there's no gold standard for that kind of metric. So
Sure.
Sorry, I went down a rabbit hole there, but yeah.
No, that was good.
I think it's an interesting goal, certainly. Like that's where we should be going, right? Is before it becomes cancer, can we find it? There are some startups out there who are very early stage, looking at ways to identify cancer by the immune system response to it, right? And then before it's even confirmed by a biopsy or anything, doing a treatment to get that eliminated, right? So that's, again, a difficult thing to study from a clinical trial because you have to follow the patient you have to follow a big number of patients and prove they get less cancer than, the people that weren't on that treatment. But I do think we'll get there. I think that's one of the pieces where it'll be a pre-cancer diagnosis and treatment. I do think we're a few years away from that.
Yeah. Well, I was selfish. I selfishly was like, wait, I'm gonna ask him about this tomorrow because I want to be clear and it seems like a semantics things as well. Like, yeah, precancerous, stage 0,
Yeah.
what are we really detecting here? But can understand how marketing teams would want to run away with that a little bit more and make it sound better.
Yeah. It does sound great, right? Stage 0, even better than stage 1.
Yeah. You're like, I'm not even, diagnosed yet.
Yeah.
Awesome. No, thanks for that, Josh. So we know a little bit more now about these multi-cancer detection tests. Like I mentioned, we have EPISEEK from Precision Epigenomics. And you mentioned a couple benefits that these tests can hold, right? And where we see these in the future. Hopefully everyone will be doing these and we'll be able to detect cancer super, super early, use them with some of the existing screenings that are available there. Is there anything else you want to mention in terms of the promise that they hold or what we can look forward to when these tests become a little bit more mainstream?
Yeah, I think there's some of the excitement I have about it is we've got, if you look at cancer incidence right now, you can look, the National Cancer Institute puts together this data and they release it every year. And they're tracking over time, right, how many stage 1 colon cancers are diagnosed and stage 2 colon cancers are diagnosed and 3 and 4. And for every cancer type, right, in every stage, they're tracking it. My hope here is that these tests become mainstream and we see a shift in that data from, we see less stage 4 cancers, we see less stage 3 cancers and more early stage cancers. And it's difficult now to model and predict because we don't have without these tools, we don't know how many people are walking around with cancer, right? We know that how many people this year got diagnosed with stage 4 cancer, but we don't know, did they have stage 1 cancer 5 years ago or 6 years ago that we could have detected with this tool? So I'm excited for some large clinical trials to happen or broad adoption of the test and us to see that shift, right? And I think we'll see that first. And then following that, we'll see changes in the cancer mortality. So we look at how many deaths from different cancers by age, et cetera, to correct for some factors. And I'm really excited to see the needle move on those things as results.
Yeah. Sounds like, there's just a lot more data to be gained and a lot more
Really?
insights to be gained. I think that's interesting. And I'm coming back to the example of my grandmother with lung cancer. I have this, chart here that's looking at cancer types, and, the 5-year survival rate, if that was detected early, was lung is still the lowest out of, breast, colorectal, pancreas, prostate, urinary bladder, endometrium. But she would have had, a 61% 5-year survival rate if that was detected early, but only a 7% 5-year survival rate if that was detected late. And, it was obviously detected very late. And I'm wondering, when did she have, stage 1, stage 2, stage 3? So like, definitely understand what you're saying and trying to apply it to like these real life situations. And, this is real science. This is a real test. This is something that can be done right now. And my parents haven't done it yet. I'm definitely going to get them in with a provider and have them do it. Their mom's 53, stepdad's a little bit older than that. But I want them to take it, once a year for the rest of their lives. Or we'll get to some of those logistical questions here at the end on how often you should be testing and who is this testing really for. Maybe that's too frequent, but I'm super excited about everything you all are bringing to the field and the technology you have too.
Cool. Thank you. Yeah.
Awesome. You hinted a little bit more at this too, Josh, kind of about epigenetics and, obviously my handle being everything epigenetics and this role that it plays in cancer. And, you can even start with like a broad definition, but do you want to add any other context and maybe how we can use epigenetics to start looking at more of these cancers and some of the research, or just how we can detect, these early signals from the epigenetic mechanisms themselves too?
Oh yeah, totally. So epigenetics are a huge part of how cancer works. And I'm guessing on the previous podcast you had on the topic, maybe you got into some details of that. But traditionally we thought of cancer as an accumulation of mutations over time, but really it's an accumulation of both mutations and epigenetic alterations, right? It can't exist without both of those things happening together. One of the pieces that I'm excited about in the field is therapy resistance, right? So patients that start on a drug and initially the drug works great, right? And so this happens in small cell lung cancer, for example, right? You'll get a drug, you'll go on cisplatin, fantastic response. Cancer may disappear, right? But we know that doesn't last. So some of the cancer cells develop resistance. They come back with a vengeance. They're more aggressive. And this time you give the drug again and it doesn't do anything to the cancer, right? And so we study resistance mechanisms in bacteria, right? If, in medical school, we've got probably 3 months of classes on resistance mechanisms and antibiotics in bacteria. And it's a good parallel for cancer. And some of those changes that happen, those resistance mechanisms, are genetic mutations, so differences in the code, in the sequence. But there's evidence pointing that the majority of them are actually epigenetic changes that happen. And so there's some work happening now where we're targeting that. So along with the primary drug, you give another drug that blocks epigenetic changes from happening, right? So can you give combinations of drugs that kill the cancer and stop it from being able to respond and change in response to the therapy? And I'm very excited about that piece with epigenetics, right? It's not a diagnostic question, and I know that's what we're talking about, diagnostics here, but I still think it's a pretty important piece of the field. Right?
Yeah, and I
Yeah.
that's an interesting point there. So now I'm thinking, okay, well, again, I don't know. I don't know if I have a genetic mutation that predisposes me to an increased rate of, some specific cancer type. I need to rerun mine. I lost my raw data file for my genetics. But, you know, say for example, someone did, right? If we use my grandmother's lung example, who isn't blood related to me, um, are you saying then there are, maybe some epigenetic expression levels that could also be related? It doesn't necessarily have to be fully genetic, but you mentioned a couple things earlier, like the environment, right? Kind of weight status or, smoking status as well. Like those are all, I think, right, things that can affect these epigenetic mechanisms. So are the drugs helping on that side? Does that question kind of make sense?
Yeah, it does make sense. I don't think we have evidence of that yet. This is in a patient who already has cancer, right? And they're already receiving treatment. I do think what you're describing is epigenetic status as a risk factor for developing cancer and as a targetable, modifiable risk factor. I don't think we have great data on that yet, but I think it's only a matter of time. I think we're going to develop it, right? We've only had these tools for a pretty short amount of time, right? We've been looking at DNA methylation for 40 years now, but that's only one component here. We've got new tools in the laboratory now looking at histone modification. There's sequencing techniques that look at methylation and also look at open reading frame, and then also RNA expression, where I think we're learning more and more about some of those risk factors that go in. So I think some of the basic science is looking at what you're describing, and it usually takes a few years to get from there, right, to the clinic, for us to figure it out. If you know any papers, let me know. I'd love to develop it to figure it out.
Yeah.
Yeah.
No, that makes sense. Yeah, my previous episode with Dr. Bird, which I'll send you her information too, we were kind of talking about like the importance of biomarkers and epigenetic clocks for older adults with cancer, and how epigenetic clocks and just epigenetic markers, kind of like the question I asked you, are just not trained on cancer populations or people who already have cancer. So they developed a really cool P16 epigenetic clock. So that's a mutation, for those listening, that's been associated with more commonly subsets and types of cancers. So yeah, it's interesting. I see what you're saying, though. It's still too early. There are a lot of epigenetic kind of factors that we can talk about, but I'm excited to see how this plays out.
Totally. Yeah.
All right, let's get a little bit more into the logistics of this testing. So the EPISEEK multi-cancer detection test that Precision Epigenomics currently offers. How does one test for this? Like, what does it actually test for? Give us some information about sample type, and then I'll stop there and ask a couple more.
Okay, yeah. So the test is looking at, we talked about this a little bit earlier in the episode, right? Some of these common endpoints where different cancers converge together and have the same epigenetic changes. The test is composed of 10 of those common endpoints. In some cancers express hypermethylation more in some of them than others. So that's the biomarker we're looking at. We're looking for the biomarker in circulating DNA and cell-free DNA. So one of the principles here is that cancer is very vascular, right? It needs a blood supply. It has a high turnover rate, a high use of glucose. And so the cells also die more often than other cells. And some of the DNA leaks into the bloodstream. We're able to collect that DNA in a tube, stabilize it, look at the methylation signatures, and say cancer, no cancer based on that. So that's the basic principles of the test. To get the test, we need a couple of tubes of blood, and we use these special tubes called Streck tubes. It's a way to stabilize cells. What we don't want to happen is the white blood cells to die, and then their DNA to cover up all the cancer DNA, and we won't be able to detect it. The Streck tubes have a special system to keep those cells intact and also stabilize the cancer DNA. We get those in the lab, we separate out the plasma, we perform the test, and get the result.
Yeah. And one question I think a lot of researchers, healthcare providers who are hopefully listening in on this, they want to know about the specificity and sensitivity, right? That's the million-dollar question. And for those who maybe aren't as familiar with those terms as well, if you could define those and then talk a little bit about how the EpiSeq test performs, that'd be great.
Absolutely. Yeah. So specificity, let's talk about that one first. That's the ability for us to call a negative sample negative and not call negative sample positive. So it's expressed in a percentage. 100% would be the best, meaning you have 0 false positive results, right? So none of your negatives are reported as positive. The specificity for EpiSeq is over 98%. We have some new numbers coming out. I wish I had them ready for you today, Hannah, but we'll get them out pretty soon here. So 98% is the current number there, a little bit higher than 98% there, which means we test 100 patients, right? We would only have a few in there false positives. Actually difficult. I'm glad we're on a podcast because I can talk at length. It's difficult to measure specificity in these tests because we don't know the truth about these patients unless we follow them for 5 years and see if they get cancer, right? So what we can do is say, hey, do you have a history of cancer? Do you have symptoms of cancer right now? But if you look at, that's who the test is designed to detect cancer in, right? And so in the cohort that we have, these are, consented patients as part of a clinical trial that we did. We had one that looks very much like cancer, right? It's not a borderline in one of the markers. It is several markers, very elevated, where I, as a physician, believe this person has undetected cancer, but I don't know this person and I don't have clinical follow-up data. So it gets murky, right? And that's true for all the competitors as well, right? There's the source of truth here is that's the question mark. So I do believe we're going to have larger data coming out with a better number. But our goal was to set that very high as a specificity because we don't want false positives. We talked about some of the negative outcomes that can happen as a false positive result where the patient's concerned, they may get unnecessary treatments, exposure to radiation maybe, for follow-up testing or something like that. We want to minimize that. That's specificity. Sensitivity is the other big statistic for these things. And that's of the people with cancer, what percentage can we detect? And the number there is 65%. We've got some new numbers coming out that are going to say at different cancer stages what the percentage is, and kind of also correcting it for the cancers that are out there in the world, right? So not just, if we test 100 cancers that we do really well at detecting, right? We could kind of game those numbers. We have not attempted to do that. That's not the case at all. So we're getting some new numbers out there, but right now the number is 65% for sensitivity. And you could look at that and say, hey, you're missing, 35% of cancers. I would turn it over and say, we are detecting over half of cancers earlier, right, before they can be detected. And if you look at it through that lens, I think it's a very positive, right? Half of cancers detected early. That's a big plus for me. So that's some of the numbers there.
Yeah, awesome. Cool. Sounds great. I'm excited to get that new data too. I know you mentioned that to me a week or so ago, and by the time this episode's out, we can link it and have the white paper
excellent.
and have all of the data here. So it'll be great for the listeners. So I obviously want to test my parents and all my loved ones like once a year, but what is the retest window? How old should you be? What about, I think we have, would it be called recurrence monitoring, right? The retesting, or that might be something different as well.
Yeah, so the kind of testing interval, we're recommending once a year. So again, you've got sensitivity and specificity here. The more frequent you test, right, the more likely you're going to catch the cancer early. And so some cancers are aggressive, right, and they go from stage 0 to stage 3 very quickly, and some are more indolent, right, and take, like some prostate cancers, for example, they might just hang out for 15 years and not really do much. And so we want to be able to catch the aggressive cancers. So that annual screening window is our current recommendation. As far as what population to screen in, we're recommending patients 40 and over. If you look at the incidence of cancer right? That's the group that has an increased risk of cancer. Um, 15 over could be a traditional screening. That was the recommendation for colonoscopies, right? It's moved back now to 45 and older in colonoscopies. So it's really, a personal decision, up to the physician and patient together to make that decision of when to test and how often. But those are the current recommendations. We will accept samples from patients under 40. It's not like anything the test won't work if you're younger. It's just kind of a, positive predictive value, negative predictive value game where once cancer is less likely in you, the chances, the probability of a positive result being a false positive versus a true positive, right? That kind of seesaw favors false positives more the younger you test. But as long as you understand that, as a physician, doctor group together, we will accept and test. We won't test children. That's the law.
Right.
We won't. We haven't validated in that population.
Sure. So what happens if you get a positive result, right? This testing comes back. Maybe people don't want to test because they're nervous or they're scared, but the goal of this testing is to not find cancer, right? And if you do have a positive result, to find it super, super early. So what are the recommendations after getting that type of result?
Yeah. Well, so the majority of patients get a result back that's a negative result, right? And that is good. That is good news. We've got a high negative predictive value, so the likelihood that there's an undetected cancer there is low. Positive result, right? We've already mentioned there's a possibility for any test of a false positive, right? That's true for mammograms, for pap smears, for this test, for Cologuard, for everything that's out there. So that the follow-up on that is really going to be based on the patient's clinical situation. We've had a few positives on the test to date. So the test just launched in April. We're still very early in, the clinical use of the test. And so, the patients, what I do when we have a positive result is I try to get the doctor on the phone to talk to them about next steps. It's part of my job as a medical director of the lab to offer that support. So if you're watching this thinking about ordering, you will get a phone call from me, your office will, and I'll hound you until you call me back. We can talk about it, or you tell me you don't talk about it. So that's one of the supports that we offer. I'm very interested in how people are using the test and what happens next. The two cases we had, the cases that we've had so far that are positives, have been situations where without a bunch of additional testing, we were able to determine what was happening, right, and get to an answer in those patients. So those were, we have some true positives where we didn't have to go chasing down a rabbit hole. Our kind of general recommendation based on talking to oncologists, radiologists, different specialists is if there's no symptoms, if there's nothing else going on in the patient, to do what's called a PET CT scan. It's a scan that looks for increased metabolism of glucose in the body. So it's something that is somewhat cancer specific and also localizes where the cancer is. It's a test that would only happen in those positives where we think something's happening. We think it's a real signal. We're confident that something's going on there. And then based on that result, the patient would have the normal workup, right? That's a normal finding that exists in the healthcare system. And you would have.
Awesome. And and last question, kind of maybe about more of the logistics here. What about people who've had cancer in the past? So I think that's what would be defined as recurrence monitoring, right?
Oh, yeah.
So if it's a way to detect when cancer returns after a period of remission. Would you recommend this for people who had cancer in the past, or maybe not? What are the difficulties there?
Yeah, so I think this test could be valuable in that population. We just haven't done the clinical evidence building, right, to make a claim on that. And so there's a few possibilities, right? So it's possible. We've got some preliminary data from a research setting, right, where these biomarkers, as a patient is receiving therapy, they go down, right, and they stay down afterwards. We don't have clinical evidence of them coming back up and what that means for a cancer. So there's a few possibilities, right? Ordering the test in that situation. One of them is it would work great in this patient, right, and would be useful for that recurrence detection. It's also possible that so epigenetic changes can have something called a field effect, right? So it could be the cancer itself has these changes, but also some of the surrounding tissue can also have the changes. They're earlier events. And so I would I would caution anyone, right, that again, until we've kind of validated this for that use case, a positive result, right, after cancer therapy may just be a result of field effect, right? So we don't
Mm.
really have the data to say, hey, this is a recurrence, this is a therapy resistance yet with this particular test. We are definitely collecting that data. We are writing grants to try to get that information. I do think this test will be valuable in that setting, but it's just not the right use case for it yet.
Got it. Got it. Awesome. We're getting close to the end here.
Yeah.
Josh, just a couple more questions. Okay, I think I've like all these questions I've been really excited about to ask, but I think the one most people are interested in and one we get a lot is the difference between EpiSeek by you all. Why should someone do EpiSeek versus the Galleri by Grail, which is maybe I think obviously was a little bit sooner to market. I know
Yeah.
EpiSeek is much newer and was just released back in April, but I know a lot of healthcare providers who are using EpiSeek as well, even though it's just been super early in terms of the launch.
Yeah, so there are a lot of similarities between the tests, certainly. So both are looking at cancer-specific epigenetic changes. I think Grail's a great company, and I think Galleri's a great test. So I want to make sure that I'm clear on
Yeah.
that. And that there are definitely differences, though, in the approaches that we take. So Galleri is using a next generation sequencing approach. I talked earlier in this call about how much I love that as an approach. Our test EpiSeek is not using next-gen sequencing. We're using quantitative PCR. So the difference between those modalities, Galleri is able to look at more targets at the same time, but it can't look as deep. So it can only look at, a few hundred copies of that. We are looking at a smaller number of targets, but the depth that we're looking to is much deeper. And so in late stage patients where there's lots of cancer DNA, both tests perform very well. Where I suspect there may be a difference in performance is at the earlier stage. So early stage cancers have lower turnover, they're less vascular, and so there might be less cell-free DNA that's out there. And so if we're able to detect a smaller amount of hypermethylated DNA in the sample, that's where we could have a better performance. I wish we had head-to-head data. I wish if anyone watching this, contact us if you want to order both tests on your patients and we can compare the results. I'd be more than happy to do that. It's really hard to do those types of studies, right? For competitors, Grail, basically none of the business people want that kind of data out there at all. But I think both tests are great options. I do think that early stage performance is where EpiSeek is going to have an advantage. And I think that's where we want the advantage as well, right? So if you diagnose a cancer in late stage, is that really early detection, right? It's really those earlier cancers that we're catching. And that's why we've optimized the test the way we did. We used the technology that we developed.
Awesome.
Yeah.
Thank you for that. All right. Second to last question here. You mentioned a little bit about what you were excited about earlier, which are all of really, I think it goes back to gathering the data, doing some comparative analyses, seeing how we can start to look at more like epigenetic factors with the drugs you mentioned earlier. But what are other areas of discovery that just excite you in this space? What do you wake up every morning just running to work and working on?
Yeah. I'm really interested in so we've done a lot of work in cancer for precision medicine, for personalized medicine, which this is part of that field. We're starting to find other diseases, right, where Acquired genetic mutations, acquired epigenetic changes are an important part of it. And the work you guys at True is part of that, right? Is some of these acquired methylation changes. I think we've seen an explosion of tests emerge and be useful in improvements in cancer. I think we're going to start seeing that in other diseases as well. And so some of the work I do on the research side of things is looking at heart attack and stroke and some epigenetic changes involved there that I think is very interesting.
Oh,
I'm
wow.
also really excited about, I think, a neurological disease.
Mhm.
We're going to see some really cool diagnostic tools and then treatments come out of epigenetics and precision medicine. So that's what energizes me is we've accomplished a lot in cancer. We're going to continue to do that work, but really taking some of the lessons we've learned, and the success we've had there, and taking it to non-cancer kind of chronic diseases that are also a huge burden on the population. That's what I'm excited for.
Yeah, that's super exciting. No, I didn't know that. Yeah, that you were excited about that or that's on the horizon. I think you said a keyword too, which was, okay, these different diseases and, detection of like neurological even, but also the treatment. Like, okay, you have this result, you may have a higher chance of getting it, but it's like, what do you do for the treatment then? So it kind of goes hand in hand. I know that's a missing piece a lot of times with, I think I've given this example before, but Alzheimer's runs in my family. I have the APOE3/4 variant. Okay, I know I have that. There are some epigenetic modifications and some papers out there too showing some things that may work, but I mean, I still have that genetic variant. So, yeah, what can you do about it at that point? I think is what we want to know next.
Yeah, that's part of the work that we
So,
need to do.
yeah, I'm excited about that. Well, Josh, I ask everyone this at the end of my podcast. I don't know if you've listened all the way to the end previously, but it's just a fun question. If you could be any animal in the world, what would you be and why?
Ooh, um, yeah, any animal. I think I'd like to be a bird. I think flying it would be such a free experience. And bird is so generic. Let's say a peregrine falcon, right? They can do
Oh,
that dive
okay.
bomb thing. They're the fastest animal. I think that would be an interesting visceral experience to fly through the air like that.
I like
Yeah.
it. I like it. You're specific. No, that would be cool. That would be cool. I think some previous guests have said like bird because of flying and stuff, but ooh, the exact example
Yeah.
there.
Well, my 4-year-old is really into peregrine falcons too. So there's
Oh,
that. Yeah, he would be excited if I became a peregrine falcon. I think
good, good.
he
You
would
can
like
show
me
him this
more.
later,
Yeah,
and
I'll show him the video.
there you go. Awesome. Well, we've come to the end of this awesome podcast. For anyone who wants to connect with you or, see a lot of research, I mentioned I'll link the research below, but how can researchers, healthcare providers, general public, how can they get a hold of you or learn a little bit more?
Yeah, absolutely. So Precision Epigenomics, we've got contact information there. We've got a feed of some of the stuff that's coming out. And then I publish work as well. So check me out on Google Scholar. I've got a page there. Feel free to ping me on there if you want to collaborate on something.
Awesome. Thanks so much, Josh. Thanks for everyone joining us at the Everything Epigenetics podcast. Remember, you have control over your epigenetics, so tune in next time to learn more about how. Thanks so much.